All right, the respiratory system, part two notes. Remember, we left off saying that about 300 million alveoli sacs cover the capillaries in your body. They're very thin. When you cough, you can burst them. So, oxygen is transported as oxyhemoglobin. That is when oxygen is attached to the heme in the globin of the red blood cells, and then diffuses from a high concentration to a low concentration across the one cell thin capillary and the one cell thin alveoli membranes. Some more practice for you. You can do this on your own, but I'm going to zip through these right now because this is, you can stop this, rewind it, whatever, practice it. So, the lungs, shape and location. The lungs have what's called the base, the flat part that sits right along top of the diaphragm. And then they have the apex, the pointy part, which is right up by your clavicles. And you can see the nasal passage comes down, breaks into your left and right bronchial tube. The patient's right bronchus, as you can see in this one, actually goes straighter down. The left one kind of goes off to the left higher because it's got to go over the heart. So most times when a patient or a kid should aspirate or inhale some small object, it's going to go down the right bronchi 90% of the time because gravity is going to pull it straight down. It's going to have to take a hard, sharp left to get in the left lung. So a lot of times doctors go down that right bronchus to pull it out. Okay, so the right lung again. See, this one doesn't show it as well, but the right bronchus does go down further. The right lung has 3 lobes. The left lung has 2 lobes. And you see the cardiac notch where the heart sits. Again, you can see you got the superior lobe, got your inferior lobes, and then you've got a middle lobe on that right lung. The hilum, again, is the point of entry. The point of entry of the bronchus into the lungs is called the hilum. The point of entry of the renal artery into the kidneys is called the hilum. Hilum is a point of entry. There's your apex, there's your base. This is a nice diagram. You can pause this. It's a nice overall just summary. Again, the hilum is the root or the point of lung entry. Wow, it's underlined, it's bold. It's good to know. So we're looking at asthmatics. Asthma is an inflammation of the bronchioles. So you get your respiratory bronchioles, your secondary and tertiary bronchial tubes. They can become inflamed. You get the smooth muscle around there constricting it, and air doesn't go through as well. That's what asthma is. So here, I like this picture because it really shows how there's just a network, a mesh network of capillaries surrounding the alveoli. And the alveoli, that they are just a simple squamous thin air sac allowing gas to exchange just from high concentration to low concentration. So the pleural cavity is where the lungs reside. That's your thoracic cavity, is your pleural cavity is where the lungs are because they're surrounded by the pleural membranes. Again, the serous membrane around them is called the pleural membrane. The pleural fluid is simply the lubricant between the parietal and visceral part of the pleural membrane. So the pleural fluid is a very fine, thin layer. So the pleural membranes again form a sac. The visceral layer is the part touching the lungs themselves, and the parietal layer is on the perimeter on the outside. It's stuck to the wall of the thoracic cavity. If it should come apart from the thoracic cavity, like you get hit really hard or you get an infection or something, and that part starts pulling off, they call that pneumothorax. When you're a baby, when you're still inside your mother's womb, you're not breathing air because you've got liquid all around you. Once you're born, at parturition, the doctor cuts your umbilical cord, and then they try to get you to take a big deep breath in, like to cry or something. And when you take that deep breath in to cry, the lungs then inflate and they stick to the thoracic cavity. So if you get a pneumothorax or a collapsed lung, they can simply stick a needle in. Here they've got a tube sticking in, and just aspirate that air back out. And what it does is pulls his lungs back out, and they stick. I've had students do this before. Their rib was killing them. They went to the doctor, had a pneumothorax. Doctor simply stuck a needle between the ribs, sucked the air out, and they're fine. Apnea, A is without, pnea means air, like pneumonia, air in the lungs. So apnea is without air for a short period of time. Sometimes at night, people will close off their thoracic cavity as they're breathing or close off the trachea because maybe they're overweight or maybe their epiglottis sticks when they're sleeping weird, but it closes and you can see the blocked airway on the right, it gets blocked. So they have devices to help with this. They have different chemicals. So a lot of people get a CPAP or they go and get a little device a dentist can make that helps keep that open. So lymph supply. This is a nasty looking thing over here. But your lymph system, you have lymph tissue all throughout the body. It takes the interstitial fluid that's fed the tissues and puts it back in the veins. It also drains junk from the lungs, and you have phagocytes like monocytes and neutrophils that will carry the debris from the lungs to the lymph vessels. So you're constantly breathing junk in that still makes it through all the mucus into your lungs. And you've got these macrophage or these phagocytic bacteria, macrophages and neutrophils, which will freely crawl around out there and engulf this stuff. Then they take it back to the lymph vessels where it can be drained to eventually get rid of by the kidneys. So debris that does remain in the lungs causes them to look gray or black. Here you have an actual smoker's lung, and you can see how black the lung is from all the tar and nicotine they sucked in. And then cancer can also spread or metastasize via the lymph vessels. There's a healthy lung. To the right is a cross section of someone who grew up in the inner city, had a lot of soot, smoke throughout the years. Didn't actually smoke themselves because it would have been a lot worse. But so a smoker's lung is on the left, non-smoker's lung on the right. You can tell, obviously, the first thing you see is, wow, those lungs are black. Second thing you might see is little blebs or bubbles, blisters on top of the apex of the smoker's lung. And those are from all the alveoli popping and breaking, and then this makes one big sack. It's nasty. And then if you also look at the heart, you'll notice the smoker's heart is enlarged because it has to work harder 24/7, not just for a few hours a day when they're training like an athlete does, but theirs has to work harder all the time. That's bad. If you're an athlete and your heart's enlarged because you work out really hard a couple hours a day, the rest of the time it is on easy street. But a smoker, your heart's enlarged, it's working nonstop as hard as it can, and that's bad. All right. Taking smoke or vaping into the lungs is now they've found vaping isn't good for you, but smoke itself causes tracheal damage. It damages the ciliated epithelial, the pseudostratified epithelial, and then that is replaced by either stratified squamous or sometimes other scar tissue, and there's no more movement of the mucus. Now the cilia are gone and doesn't suck that mucus down to the stomach. That's why you get a smoker's cough. Mucus accumulates in the trachea. You do get respiratory infections more because the mucus stays there so long that the bacteria or virus have higher chance of getting down to the tissue below the mucus to cause the infection. And then you do get irritated in the trachea, you get inflammation, and that stimulates the cough reflex, the smoker's cough. I need another cigarette. Again, normal lung, smoker's lung. Three differences: the color, the emphysemic blebs up there, these blisters, and the size of the heart. All right, some things you need to know. Definitely need to know. Good to know. You practice these and learn these in the lab. But tidal volume is the amount of air you're breathing right now. Just that little 500 milliliters of air that comes in to your mouth and back out through your mouth or nose, whatever it is. So it gets a little bit of change in the lungs down there. So inspiratory reserve volume is how much you can inspire or breathe in above and beyond a normal tidal volume. So a big deep breath in after a normal breath in is your inspiratory reserve. It's my reserve. So if I've got an inspiratory reserve, I probably have an expiratory reserve, which means after I breathe out, relax my diaphragm. Now I can force myself to blow out all the candles using my abdominal muscles, pushing my gut up into my diaphragm, using my internal intercostal muscles, squeezing my ribs in to force air out above and beyond a normal expiratory breath. So that's called your expiratory reserve. Add all three of these together, and you've got what we call the vital capacity. Here's a nice chart if you like seeing things mathematical like I do. The vital capacity is your inspiratory reserve plus your tidal volume in normal breath plus your expiratory reserve. If you look at the very bottom down there, it's called a residual volume. No matter how much you blow out, you think you're done blowing out, your lungs still have air in them. They just haven't collapsed. So there's a residual volume of air in the lungs just because your lungs don't flatten out and collapse. They're still stuck to the thoracic cavity, thank goodness. And then you've got this other thing down here called FRC, but we're not going to talk about that. Okay? All right then. So practice know these in your lab. Example, Caroline comes into class, picks up the Voldine inspirometer. She takes a normal breath and measures 500 mils. Then after the normal breath in, she continues to inhale 1,000 milliliters more. She then decides to measure as much as she can inhale in one huge breath, and it measures 2,300 mils. Since she did not use the wet spirometer and could not measure her expiratory reserve volume, she needs to do some math. What is her expiratory reserve? So below you have, in yellow, you have the equation, which I threw at you earlier, is your expiratory, inspiratory, and tidal volume all equal your vital capacity. So that's pretty easy. Take 2,300 minus the 1,500, which she measured, and you get 800 mils. So her expiratory reserve would be 800 milliliters. So they break that down. You can rewind this if you need to. Go back and listen to it again. All right, surfactant is this very thin little fluid on top of the alveoli, which keeps them from sticking. So with surfactant, the alveoli pop right back open again. Without surfactant, they'll stick because little thin water things stick. So surfactant is important. That big word surfactant up there, it's important. You want to see how it works? It's got a little YouTube link down here, which is excellent. It's short, super short. Copy it, play it, watch it. It shows it in action. It's a cartoon, but it's basically these little phospholipids and lipoproteins, that is, little oils that reduce the surface tension so they can pop open again. Surfactant, know it. Remember, get your job shadow journal turned in on time, and that is the end of the respiratory system notes.